men,
Any
both
mass order
LUTS
Odisha, yes.
as well
Yes,
as
order Odisha. Yes, mas. List yes, mas. I put a more order Odisha.
Rajendra, can you mute that? The young male, the LUTS. I request President Changal Rayan sir to give opening remarks. After that, we'll proceed with the talk. Who are talking, they will be unmuted. So over to President sir.
Unmute sir, please.
Yeah, thank you. There were incidences where when we were students, people have taught us that don't make a diagnosis of BPH if the patient is less than 50 years. But all through in our practice in the last 20-25 years, we have seen so many patients presenting to you in a younger age group, 40 to 45. Still, you make a diagnosis of BPH when you see and treat them accordingly. May not be surgery, but at least in medical management. Same way, I have seen patients around 40-45 years presenting with obstructive symptoms and mild elevation in PSA. If you do an MP-MRI, you find a suspicious lesion, and then your PSMA PET shows positivity for malignancy. So this aspect of young males presenting with benign prostatic hypertrophy as well as carcinoma prostate is something which we have been seeing regularly. Maybe because of the advent of our investigations or more our thinking into all these aspects. But this is one segment which is very difficult to treat. So I think it is time for us to think about it. We have two wonderful speakers. Dr. Ginil Kumar is going to speak on carcinoma prostate, and Dr. Ravi Kumar is going to speak on a young male presenting to you with BPH. I think for the next 1 hour, it's really going to be interesting. It will be extremely useful not only to the clinicians as well as the postgraduates if they have an opportunity to join this program. Thank you very much. Over to Chandramohan sir. You can invite Dr. Ravi Kumar sir as the first speech.
Yes, sir. Yeah. Thank you, President sir. And I request Rajendra on the screen the CV of Ravi Kumar sir. Otherwise, I can read. Yeah. Thank you, Rajendra. This program is sponsored by CIPLA for the internal programs where it will be useful for the PGs. Dr. Ravi Kumar sir, who is the first speaker today, is from Hyderabad. We know him for last 20-30 years. He is one of the teacher, even though he is in private practice. He taught many people the PCNL and RIRS. Presently, he is working in Medicover Hospital, which has robotic technology also. He is also enucleation specialist as well as robotic surgeon. With his vast experience of nearly 40 years in Hyderabad in private practice, let us listen from him the LUTS in young male. As President Changal Rayan sir said, a lot of people not only coming with the lower neural tract symptoms in young male, many are asking for the treatment also. Minimally invasive surgeries are also focused on the young male. So taking this relevance, we have selected this topic, and I request Dr. Ravi Kumar sir to take over the program for the first talk. Over to you, sir.
Unmute, sir. Sure. Okay.
Yes, sir.
Rajendra, you have to help sharing. I made you co-host, sir.
You click below. Yes, sir.
Yeah.
Yes, sir. We are able to see the screen, sir. We are able to listen to you also.
Thank you. Yes?
Yes, sir.
Close this.
Yes, sir.
Okay. Good evening, all the members of ASU. Audio is clear?
Yes, sir.
Yes, sir. Yeah. Thank you to Dr. Changal Rayan and Dr. Chandramohan for inviting me to give this talk. lower urinary tract dysfunction due to BPH in young males is a fairly new topic, because as Changal sir was just telling, earlier we used to think that this is the problem of the old people after 65 or 70 years. But nowadays we are seeing a lot of young patients, maybe because of the master health checkups that are being undertaken, and also because of increased awareness and increased awareness of carcinoma prostate also. Many young patients are coming to our clinics uh, with symptoms of BPH.
Rajendra, his voice is coming.
Sir, changing the slide, sir.
Yeah.
Sir.
What?
Is the voice, are you able to listen his voice?
Yeah, yes, sir. Yes, sir. Able to listen, sir.
Okay. Yeah. The slide changing is a little slow, so I got a little confused. So even though most of the patients we see after the age of 60, nowadays we are seeing young population. And what is our interest in this young population? Why are they important to us? The main reason why they are being important are at this age of up to 60, 65 years, they are all very active in their work, and they are all very productive in their work, and most of them are still working very actively during this age. And up to the age of 60 years, they are sexually very active also. So what happens is, with the advent of this BPH symptoms, these patients become very disturbed. If you see the prevalence, this slide is from 1997, where you see that about 25% of the BPH patients were in the age group of up to 49, 37% in the age group of 59, and up to 69 years, there about 37% of the population was having symptoms of BPH. So in these age group, the major problem is they are very active in their professional life, and this causes a lot of problems for them. And the suspicion is, are these symptoms and this kind of population, is it increasing? So when you see in 2014, about at the age of 40 years, about 8% of the population had symptoms of BPH, and at the 60th year, 50% of the population had symptoms of BPH. And when you see that the new thing that has come up is BMI, as obesity is also increasing, it has been found that 3.5-fold increase in the risk of prostate enlargement due to increased BMI. And when you see the prospective trial that was made in USA, where 51,000 patients US men were studied from the age of 40 to 75, the incidence has, as you see, is slowly increasing from 40 to 54 years. About 10% of the population is complaining of the symptoms, whereas you go to 60 years, about 20%, and it steadily keeps increasing. So this prevalence, as we see, is still increasing in the recent years. So what is the major concern here in this age group? In this age group, the major concern is that because of their very active professional life, there is an decrease in the work productivity, interruptions during working hours, decrease in the concentration, and disturbed sleep in the night. Especially in people who are not retired and who are working, there is a great fear of not being able to access the restroom in time, which leads to a lot of anxiety. I have known patients who, when they are going to a boardroom or when they are going to a new office for any business discussion, they put on a diaper because they are scared that as soon as they go into a new office, you will have to ask for a restroom and where the restrooms are. So these people are so disturbed. So these urinary symptoms results in a lot of frustration, a feeling that they are not in control of their life. So that causes a lot of distress in these young people. And I have known several people who have stopped going to major functions and social events because of embarrassment of these urinary issues. Not only does it cause the urinary disturbance, but it also causes a lot of disturbance in their personal lives. Because of the urinary disturbance, it causes loss of libido, difficulty in maintaining erections, and low levels of sexual satisfaction. When you see an analysis of about 10,932 patients with a diagnosis of BPH, many of them have complained their inability to maintain erection throughout the sexual intercourse, where sometimes about 30% of them said that sometimes they are not able to maintain, and another 30% said that few times only they were able to maintain their erections, and 17% had a total loss of erections. And the satisfaction levels of the intercourse have also gone down in these people. So far that 47% of the patients said that achievement of their satisfaction is less. So even though we know that active and working lifestyle positively correlates with better sexual desire, better sexual activity, and good adjustment, many people also suffer from the previous symptoms of reduced sexual intercourse. So this is where the challenge lies, because for treating these young patients with multiple drugs, which have got their own side effects. With the advent of the alpha blockers, many symptoms have reduced, but only alpha blockers, if we see a patient who has had alpha blockers for 3 months, his IPSS score was previously 15.6 and Qmax was 12. It reduces IPSS to 10 and Qmax to 15, but that itself is not sufficient. What we have to aim for is IPSS score of less than 8 and a Qmax of more than 20. That is where the patients will feel very satisfied. So how can we get more than what the alpha blockers alone are not able to give? And what about the various side effects, especially of tamsulosin and silodosin? They cause both ejaculatory dysfunction, erectile dysfunction sometimes, and anejaculation many times. And many of the surgeries that we conduct for the prostate have their own side effects, which are not very much agreeable to the young population. So many of the surgeries are unsuitable for this younger population. So how can we treat these patients with cost-effective and safer options in these patients? Many of the drugs, in the treatment here, of course, with the active lifestyle, healthy diet, exercise, stress reduction, and yoga and other things, you can modify some of the symptoms of BPH. You can use alpha blockers, you can use 5-alpha reductase inhibitors, you can use PDE5 inhibitors, and you can use the combination of all these things. And lot of minimally invasive surgeries have come in, like aquablation, cryotherapy, intraprostatic various stents, TULEP, HOLEP, and various other surgeries have come in. But all of these have their own disadvantages, which we'll be seeing a little later. The American Urological Association as well as EAU have been suggesting that irrespective of comorbid erectile dysfunction, we will have to discuss a combination of low dose tadalafil with alpha blockers in these patients. Even though all the 3 alpha blockers that we commonly use, tamsulosin, silodosin, alfuzosin, are equally effective, tamsulosin being causing a lot of abnormal ejaculation, silodosin causing retrograde ejaculation or anejaculation is what we are calling nowadays. Alfuzosin has got the least sexual side effects. So that is the main advantage where we are focusing today on alfuzosin. And why do we use select tadalafil is because of its half-life, which is very high, almost 36 hours when you compare to sildenafil 4 hours and avanafil 3 to 5 hours. Tadalafil has got a very long life and can be used as a once daily long-acting drug. And this is tadalafil is the only PDE5 inhibitor which has been approved for use in lower urinary tract dysfunction. So the combination of alfuzosin and tadalafil has come in this way that they are both very long acting and they have very low erectile dysfunction problem, leading to a perfect match. So they have complementary mechanism of action of both alpha blocker and the tadalafil. Alpha blockers relieving LUTS by inhibiting the alpha-1 adrenergic receptors, and tadalafil by increasing nitric oxide in the penile smooth muscle, improving erectile function. And this also acts by improving LUTS. These are the theories that have been propagated, like down-regulating RHO kinase activity, modulating ANS overactivity, and modulating afferent nerve activity. So there are a number of studies which have proven that the combination of alfuzosin and tadalafil 5 mg are very effective in treating both erectile dysfunction and urinary tract infection. The fixed dose combination of alfuzosin 10 milligrams and tadalafil 5 mg And plain alfuzosin, if you compare on the flow side, you can see that at the end of 4 weeks, the fixed drug combination has given an improvement of 5.77%, whereas only alfuzosin has given an improvement of only 3.9. And in the same way, the improvement has increased. If you see on the 8th week, the improvement is 8, whereas only alfuzosin is 5. And at the 12th week, the improvement is 12, whereas here it is only 8. So whatever improvement you are getting in the 4th week, only alfuzosin you are getting in the 8th week. And similar, you can see that the improvement is much higher in the fixed drug combination rather than using a single alpha blocker. So this is showing an earlier improvement of LUTS due to BPH with a fixed drug combination rather than monotherapy. And in a similar way, it also, if you see the flow rates also improve significantly more than in the fixed drug combination than in alfuzosin alone. So fixed drug combination has a good safety and tolerability profile, very mild adverse effects are seen even with the combination. If you see the combination drug, the adverse effects, very mild effects are seen, like headache, dizziness, flushing, fatigue are all in the mild category only. And if you see the blood pressure also, the blood pressure in a combination with alfuzosin and tadalafil 5 milligrams, the change in either the heart rate or in the blood pressure is very minimal. It's very minimal from the baseline. So the tolerability of this drug, a fixed drug, is very good. So the fixed drug combination of alfuzosin and tadalafil was safe and well tolerated from an overall as also postural hypotension viewpoint. Also, the effect was very minimal. So the drug has been very well tolerated. There are Indian evidences also that alfuzosin and tadalafil combination therapy for LUTS and erectile dysfunction. So the results are that the erectile IPSS score has gone down and the erectile dysfunction has improved significantly when we are using combination therapy of alfuzosin and tadalafil. Here you see the improvement in the erectile dysfunction score. There's another Indian evidence of efficacy of alfuzosin and tadalafil combination therapy in LUTS who have had a partial response to alpha blocker. Here, 2 groups of patients were studied. In group A, they are given only alfuzosin or tamsulosin. And in group 2, these are the patients who did not have a good response to alpha blocker alone. Tadalafil was added to these patients. And if you see in the group who did not have a good response to alpha blocker and where tadalafil is added, their response significantly improved and came almost to the responsive group. So non-responders to alpha blocker alone, if you add tadalafil, there is a significant improvement in the IPSS score in these patients. So an add-on of tadalafil 5 mg once a day, 2 alpha blockers produced remarkable improvement in the IPSS score, in the Qmax, in the quality of life, and reduction in post-void residue and erectile dysfunction in these men. So this is where the combination of this bio turbocharging has come in, and it will definitely lead to lot of improvement in the patient's life. It increases the flow of urine from the bladder, leading to reduction in lower urinary tract symptoms, boosting the flow of blood to the penis, leading to happiness and sexual improvement in the desire, and there is no reduction in the semen quality or quantity, thereby leading to very good improvement in these patients. So to conclude, combined therapy improved erectile dysfunction and LUTS, as demonstrated by a significant improvement in uroflowmetry, in IPSS score, and the erectile dysfunction score, as well as the quality of life assessment in these patients. This is the combination drugs where there has been a very good improvement in erectile dysfunction, in Qmax, and a reduction in the IPSS score. So even though all the other things have also to be encouraged, like education of the patients regarding BPH, physical activity, healthy diet, fluid management and caffeine restriction, and good sleep, and all these things. The addition of tadalafil to alfuzosin leads to a significant improvement in these patients. I have used this drug in a significant number of patients, this fixed drug combination, and very few patients had to withdraw this drug because of the adverse effects of tadalafil, because we are using only a very small dose, a 5 milligram dose. So the adverse effects are very minimal, and I have used this drug even in patients up to 70 years who are sexually active. So these patients, when they are sexually active and you give them the other drugs, tamsulosin and silodosin, they come back after a few weeks, and slowly they tell when they are leaving that they are happy with the LUTS part, but sexually they are very unhappy because it has caused a lot of anejaculation in their sexual life. So I, even in older population, I had to shift to alfuzosin with tadalafil in these patients to make them again happy in their sexual life. I thank all of you for the opportunity given, and any questions and queries and discussion, I think we can have.
Thank you, Ravi Kumar sir, for the wonderful presentation. I have two questions for you on behalf of the audience. But before that, can you hear me, sir? Ravi Kumar sir, can you hear me?
Yeah, very well, sir. Clear.
Yeah. The excellent point which you made is because we are talking about young males, the drug of choice is obviously alfuzosin. Alfuzosin doesn't cross the blood-brain barrier. So
Yes, sir.
naturally, because of its poor lipophilic abilities, it doesn't produce the asthenia, tiredness, or erectile dysfunctions related to the brain activities. That's great. One or two of my patients had still had a retrograde ejaculation with alfuzosin. And the older patients of mine always had a postural hypertension. But young males, obviously, alfuzosin becomes a drug of choice. And tadalafil, by increasing the vascularity to the prostate as well as relieving the prostatic congestion, and giving a little bit of erection that prevents the post-maturation dribble adds to this effect. Wonderful that alpha-zosin tadalafil is probably the combination which you're looking for in a young male. How many of your patients, in spite of your treatment, ended up finally with surgery, sir?
I would say that not more than 5% of the patients of mine have requested for surgery. Most of them are very happy with this combination. Few people who had a prostate of a bigger size, like 50 grams or 60 grams, these patients, sometimes they do complain that they are not very happy, but they are really scared of the other side effects of transurethral resection. In these patients, we are now offering the newer methods of urolift or the other procedures, so that they are improving with these newer procedures.
Good, sir. Good, sir. And when it comes to 2.5 milligram of tadalafil, generally we don't do any cardiac testing at all in these patients.
Yes.
When it comes to 10 milligram or 20 milligram, always see the cardiac evaluation, the liver function test. But 5 milligram given on a daily basis, do you recommend a cardiac evaluation in these patients? Or
Yes.
patients who are already taking nitroglycerin or something, you try to avoid this 5 milligram?
Not really, sir. Only in patients who have cardiac complication, or I mean cardiac symptoms, or they're on drugs for cardiac diseases. Only then I go for evaluation. Otherwise, in other young males, directly we can use this medicine without any problem.
So, when patients who have already been taking some nitroglycerin and some cardiac drugs, you
Yes.
feel it's better to avoid this drug. Otherwise, it is not necessary to go a routine evaluation of cardiac evaluation in these patients. There
No.
is one message that has come. Is there a role of urodynamics in a young male who presents to you with obstructive LUTS?
Not routinely, sir. If the alpha blocker or the combination of this fixed drug is not effective, it is not giving them relief even after 1 month, uh, or the irritative symptoms are very high, only then I go for urodynamics. Otherwise, I routinely do not do urodynamics. I will first start them on alpha blockers, then go for the fixed drug, this thing, and if the irritative symptoms are more, I will add anticholinergics. Still, patients are not happy, only I'll go for urodynamic test.
Patients who had a combination of dutasteride with alpha-zosin or silodosin or tamsulosin, in those patients, an addition of 5 mg of tadalafil, have it found it more significance? Patients with big prostates already on a combination of dutasteride with an alpha blocker.
Hmm, actually, if
Or the combination doesn't come in the market, still we can add a 5 mg tadalafil for those patients because we found it useful in our practice.
yeah, I have used, but most of the time I try to avoid dutasteride in a sexually active male,
Yes.
because sometimes I have seen that once the erectile dysfunction sets in, it takes quite some time for it to come back, even
For the
after
patient to psychologically recover itself is a big this thing.
stopping the dutasteride. It takes quite some time for the erectile erections to come back, uh, producing a lot of distress in the patient, and of course, he making a lot of visits to our outpatient and questioning us on when he is going to get back his erection.
Thank you for the wonderful presentation, Ravi Kumar sir. Big round of applause for you. Wonderful. I think Chandramohan sir, we have to thank Ravi Kumar sir for a wonderful
Yeah.
presentation. And you can invite the next speaker on stage with this small intro.
Yeah, Dr. Ginil Kumar is well known for all of us. He is also past president of the Association of Southern Urology, and he is a professor, Department of Urology, Amrita Institute, Kochi. Dr. Ginil Kumar sir is chairman, Collaborative Research Committee, USA. He has a lot of interest. He is interested in giving the education to the youngsters to involve in scientific research, writing papers, and his fellows are also doing well in that respect. And he is founder trustee of Society of Genitourinary Oncology, Robotic Urology Forum, Academic of Uro-Oncology, past treasurer SOGO, and past council member also USI. With this introduction, I request Dr. Ginil Kumar for taking over the next topic, that is carcinoma prostate in young male. Again, an interesting new subject for all of us. Over to you, sir.
Am I audible? Can I share my presentation?
Yes, sir.
You are now co-host, sir.
Okay.
Yeah, your presentation is visible and audible, sir.
Okay, thank you. So, as Chandramohan has rightly told, is an interesting topic. Not only because I'm a uro-oncologist, because recently we find that a lot of patients has got prostatic malignancy even in young age, and it causes a lot of confusion. Not only for the patient, for the doctor also. For the patient, they are actually psychologically upset when they are finding something that is very dangerous, especially when even though everybody knows that prostatic malignancy has got a slow growing and it is very unlikely that can cause harm to their life. But in young age, they're going to live for long life, and most of the issues related to the treatment is concerned about is towards the sexual aspect for the young age patients. If it is a hormone or radiation or surgery or whatever be, it can severely impair the quality of life. So it is a very important concern that about the quality of life, as Dr. Ravi Kumar sir has rightly told, in the BPH setting. And in prostatic cancer, that is even worse. I'll just go through a patient whom I treated recently. He was 45-year-old. And when we was routinely having a medical evaluation, somebody sent PSA. Usually nobody sends PSA at 45 in the medical evaluation if there is no family history, or if other indication is some ethnic population like Africa, American who has has got very high risk of prostate malignancy, or if there is a diagnosed abnormality in the genetic nature of in the family like BRCA, breast cancer, or any other malignancy, we wouldn't have sent. But somehow somebody sent the PSA and it found that it was found that PSA is 7. So when there is an elevated PSA of less than 10, always is better to have a repeat. And it was again found to be more than the initial value. And he was rightly evaluated with the MRI and found to have a pyrite lesion. And because even though he was 45, he was evaluated from outside and found to have a prostatic malignancy. But after the biopsy, he was evaluated with a PSMA PET scan. So all the issues happened after that, because he was worried because there were multiple lesions, one in the rib and one in the sacrum in the PSMA PET scan, and also in the thyroid. Thyroid, with this report, he came to us. So the family was upset. He was coming with the father-in-law, and he was upset, recently married. So has got a child which is only 3 or 4 years old. So the thyroid evaluation showed a thyroid 4 lesion. Just biopsy, again, it came as a paprika. So the upset was increased. So one thing about the young age population, there can be family history of malignancy. Sometimes multiple malignancy can occur. There can be some genetic abnormality. All these things occur in young age population. So young age malignancy in prostate or in kidney or wherever be, there are a lot of other things we have to think of apart from the tumor alone, the psychological upset, the financial issues, then the genetic predisposition for multiple tumors, all these things, and the possibility of having a tumor in the next generation family, all these things has to be considered. So this patient has a papillary carcinoma, and naturally the papillary carcinoma was given a privilege or sent for management of that. And on evaluation, found that he underwent a total thyroidectomy for the thyroid malignancy, and lymph node 1 metastasis was there, and he was planned for a ablation, nuclear ablation for the thyroid. So this was the situation, and meanwhile, he approached another doctor. They started a GnRH agonist for the prostate cancer, seeing the PSMA PET scan. So my concern was this is only young age, and these two lesions, the sacral lesion was not very much conclusive, and rib lesion was having a comparatively high SUV, close to 5. Other sacral lesion was very low SUV. So since the PSA was 7 and the biopsy grade was very low, like it was 3+4, I suggested a biopsy, but the biopsy of the rib as a first option to see if there is a metastatic. When the metastasis, the entire treatment changes. But he was, after that, he went to outside and started on a GnRH agonist with bicalutamide. So then they came to me. I told I would like to have a rib biopsy anyway. Then since the hormone treatment was a few days back, within 1 week, I just requested for a early rib resection biopsy, and that biopsy showed a benign bone lesion that was active in the PSMA PET scan. So PSMA PET scan sometimes may not be very accurate. If you feel that there is the PSMA PET scan biopsy and PSA doesn't correlate, probably in this kind of situation where we want to avoid a radiotherapy or hormone treatment, probably we can confirm with biopsy from the optimal site and see if there is any possibility of avoiding the hormone treatment. Because hormone treatment in young age, or uncertainty in the young age to continue hormone treatment lifelong, is a big decision. I am not saying metastatic malignancy cannot occur in young age, but always when there is a disparity between the biopsy report and the PSA level and the PSMA PET scan, there is a small possibility that PSMA PET scan can be false positive, that can occur. So after discussing with the patient that there can be an issue, but an option of RARP can be considered if the PSA is coming low. After that, there is a possibility that rest of the lesion also is benign. So we proceed with a robot-assisted radical prostatectomy with nerve preservation. And now, after 1 year, without any hormone, the PSA is undetectable, less than 0.002. And the PET scan at present found to be normal. So what I want to highlight is actually a young age, there can be a lot of diagnostic dilemma. PSMA PET scan sometimes can go wrong, and if there is any issue in correlating, we have to go for the next step. Especially in young age, every attempt should be to avoid a treatment that can cause harm in long term, like a hormone or a radiation. And there are some centers I have seen that in young patients, when there is a multiple, even metastaticectomy is done to avoid a hormone or delay a hormone. So these are the way in which the discussion were going on in treatment. But when a patient is coming with a CA prostate in young age, what are the options we have? So as any other patient with CA prostate, if he is organ confined, we have active surveillance, RARP, and radiotherapy. Which one will you go for? Second, another thing is if we are presenting, I have got one patient who is around 37 years old, presented with metastatic. So metastatic patient, I haven't added in the slide. Metastatic patient, it is always possible to go aggressively if they are, especially if polymetastatic, with trimodality treatment, including hormone, ADT plus ABI or darolutamide along with chemotherapy. And another option is if it is oligometastatic, we can treat the prostate and treat the metastatic lesions as aggressively and continue with the hormone with a idea of avoiding hormone at least for some time. So options in locally organ confined tumor. So lot of patients, first question for me when a patient in young age comes will be whether I can avoid a treatment by going for an active surveillance. So first I have to assess the risk. If the patient is a low risk category, always our option will be to have a active surveillance. But if it is an intermediate or high risk, these patients, we know that these patients can have a metastasis in the productile. It was actually in the even in intermediate risk. If you are having active surveillance, they can have chance of metastasis high when the duration of life expectancy is more. So these patients, when they are presenting with intermediate or high risk, aggressive treatment is required. What aggressive treatment I would like to have is with RARP and adding a radiation hormone if at all it is required. Because why I want to avoid a radiation at the young age is because radiation has got a chance of second malignancy in long term. So avoiding and hormone has got morbidity, psychological impact, issues with the erection. So all these things, then there is in the long term, there is a possibility of emergence of a neuroendocrine type of differentiation in this tumor. So every aspect, I want to completely get rid of the tumor if possible. And RARP will be the choice. But if it is lymph node positive or beyond that, I may have to combine with a multimodality treatment to avoid. And oligometastasis, in our protocol, we go for radiation since the survival advantage with surgery is not yet clearly defined. So if it is a oligometastasis, we treat the prostate with radiation and add a combination treatment with ADT and one more agent for the metastatic lesion like abiraterone or enzalutamide or darolutamide, whatever. So these are the managed options. So aim of treatment is, if possible, AS or any intermediate or high risk, preferably either RARP or a RARP starting with multimodality treatment. If the patient is not willing or don't want to take even a small chance of surgery-related complications, then RT or CyberKnife with ADT, brachy with EBRT. All these things are options. So these are the way in which this is based on the case I was discussing with the management. But more interesting is how important is this issue in our community? So when these patients are often not detected or are misdiagnosed in the community because of a lot of factors, when a patient coming with a voiding symptom, as Dr. Ravi, there's a lot of, Ravi sir has told, there's a lot of diagnostic confusion. There's a issue with the treatment. So the patients are often either by the urologist or by the suggestion of the patient, they try to defer the treatment mainly because of the psychological impact. And we always think of chronic prostatitis, and majority of the patient would have gone for multiple cycles of antibiotic treatment before they go for evaluation. This is one of the factors because of which the patient may present with an advanced stage or advanced status, even in metastatic sometimes. It's not because the majority of the case may not be due to the the disease factor because of the delay factor. That is obviously seen in some of the registries in outside, even in the US registry, that these patients are misdiagnosed or not evaluated properly. Okay. Metastatic evaluation often is not done at a proper time. Another thing is always there is a belief that CA prostate is a disease of old, and even if there is a warning symptom, sometimes we may not do a PR, or we may not do a PSA before we embark on the treatment. So rarely, very rarely, this can occur in young age, and we have to consider whenever we are treating a voiding symptom in a young age or a prostomagaly in the young age. Even though BPH can be calmer, but CA prostate can also occur in young age. Another thing is, it is a slow belief that it is a slow-growing disease, and we can defer the treatment, delay the treatment without proper metastatic evaluation, and this may not spread in the at least for a few years. But it is not always true. There can be aggressive patients. In fact, some of the registry shows that CA prostate can be more aggressive in younger population. So this is one of the factor we have to first risk stratify the patient. Then you can decide about whether we can avoid treatment or not. So always when there is a doubt about CA prostate, we have to evaluate. And another factor is the psychological impact of diagnosis. So majority of the patient doesn't want to go for treatment because of the issues, psychological impact of probable impotency, because the family, if they are knowing, then probably it can cause psychological trouble in the family. All these things are more in the younger population, so they delay the treatment sometimes. Then obviously there is concerns about the morbidities of treatment in this population. So at the other end, our concern is about this is a very active age group. They have longer life expectancy, and if you are missing something that can severely impact the life of this patient, and another thing in this patient is that chance of hereditary cancer. So it is very important to diagnose this cancer, evaluate for any hereditary factors if at all it is there, and counsel the patient and the family properly about probable issues related to hereditary possibility of malignancy. And this patient has got more economic and social implication if they are diagnosed in the early age. So these patients are stronger psychologically and can less likely to have comorbidities and can withstand aggressive treatment. So when a patient with metastatic or aggressive treatment comes, the treatment also has to be aggressive so that the chance of cure can be improved. So, whatever treatment we are giving, these patients are going to have the longer period of side effects. Like these patients, if they are having a radiotherapy, can have a second malignancy in their lifetime, unlikely to happen in a patient who is 70 years. But if there is a radiation is done, they can have a malignancy after 15 or 20 years, either in the rectum or in the bladder. So this also has to be considered. So all these things are implications of diagnosing a CA prostate. How young a CA prostate can happen? This is often the question that is asked by a lot of people. And it is reported even in AYA, that is adolescent, young adults, that is around beyond 25. And a lot of patients are presenting now with less than 50. So which has to be the age below which we have to consider that is a young prostate. So in few of the papers from US, it was considered to be 45, and some other papers is 50. And another paper is 35. So there is no cutoff, but it is a cancer prostate is increasing in incidence recently in this group, younger age group, is definitely shown in a lot of registries. So below 40 years, the incidence data in the paper which is published in Cancer, we can see that the youngest in that was 13 years. So this can occur in our population. And the chance of malignancy exponentially increase beyond 30 years. Up to 13 to 30 is a slow increase, and beyond 30 that exponentially increase, and beyond 40 that we can see that a lot of patients in our database, there are patients are below 50, between 40 and 50. Another point which is discussed in this cancer paper is that chance of omitting a metastatic evaluation is higher in younger patient compared, and is inversely proportional to age. So if a patient is 30, the chance is higher than the patient is at 40 to have no metastatic evaluation before treatment. They would have just gone for multiple treatment even without having a proper treatment for this patient. So when we can see that below 25, around 50% were unstaged in one of the best registries, that is US registries, is that registry. So if it is happening in our community, we may not get surprised because this is from the best registry of the world. And when it goes beyond 25, we can see that the chance of understaging or unstaging is reduced, like 9% of 25 to 40 patients are only having CA prostate which was not staged. And if it is more than 40, almost 96% in that register were properly evaluated, metastatic evaluation was done. So because of this factor and because of the delay, the chance of presentation with metastasis were higher in less than 40 patients in the CIS data analysis. Another factor we have to see in this patient is the chance of genetic abnormalities. There are few genes which are commonly seen in this patient. One is the BRCA1 and 2, HOX, MB3, Lynch syndrome, and other genes like ATM, CHEK3, PAL-B2. All these genes, especially BRCA2 and both HOX B13, are very important in this age group. In the CIS data analysis we discussed, we can see that the graph of CA prostate that is in black, that is increasing in the last 20 years, may be related to more and more use of PSA, but the incidence increase. And suddenly there is a dip. That is when the US task force told that screening is not beneficial in CA prostate. There is a dip. At the same time, you can see that the death was slightly reducing, but suddenly it has increased. So, and the chance of death is very much low compared to the chance of death in kidney cancer in this age group. Obviously, because these patients, a lot of patients are not very high risk patients. But compared to that European data, we have a BGO article tells that in a large pool, there was 3.3% of patients were below 50, and they had there is an increase of presence around 3.6% increment of there in the chance in the prevalence or in the incidence of cancer prostate year to year. So it is not only in the US side, European side also, they can see that there is increase of CA prostate 3.6% every year. So in Africa, there was a paper from Nigeria. They also showed the same thing. And in Africa, we can see that the chance of CA prostate was very high, 8.86% compared to 3% in the West. So we also analyzed our database of the recently, we had a collaborative research study on the banner of US side. And we were actually, I was the PA in that. We had from 42 centers, we collected the biopsy of 2,473 patients. And in that, we found that 1.81%, there were 45 patients of these patients under 50 were under 50, not 45, under 50. So probably in young age, probably there is underreporting, or actually our prevalence is lower. When we analyzed our institutional data, it was around 4% of our radical prostatectomy patients were below 50. So this almost corresponds to the data from the European side. European side, that was not the community-based, it was radical prostatectomy-based data, and it was almost similar. We also had. Risk stratification, surprisingly, in the European side, actually younger patient had a better risk, low risk compared to the older patients. That was not seen in the Chinese paper, which has recently published. They found that it's almost like how we see in our community. Like there are a lot of patients in this, out of around 100 some patients, around 110 patients, 69 were high risk or higher stage, and they were 40% was the survival in this patient for long term. And a lot of patients presented with lymph metastasis, osseous metastasis, probably they were diagnosed in a delayed manner, and they was understaged initially, and they was misdiagnosed. So they were presenting with metastasis in this Chinese paper. So it may not be different from our population. So in US side also, we find that a lot of patients are having a higher stage if they are below 40. And when they are coming to almost 40 plus, they are almost comparable with the general population. So why there is a difference between different community? Like in the US cohort and China cohort, we can see that China cohort, they are presenting at a later stage compared to the European cohort. Also in US also, we can see it is in between. Probably this is because of the misdiagnosis that is happening in the late treatment. This is more in Chinese versus US, and European side it was even better. In these patients, there is around 60% possibility of more patients in high grade in the Chinese population compared to low risk of high grade in the European population. So there's a difference based on how they are evaluated, how the ethnic difference are there. There is a difference in the percentage, the presentation of high risk. So hence, the treatment given also will be different in this population. So to conclude, less than 50 years, CA prostate occurs in 2 to 9% from different parts of the globe. We have to have an early detection before this patient progresses to T3, T4 disease. Genetic screening, whenever there is a family history or genetic alteration suspected. When we have to suspect genetic alteration is when there is a CA breast or intestine malignancy. CA breast is, there is a mainly it is BRCA2, CA colon, it is the mismatch repair. All these things can happen. So if there is BRCA positive, BRCA positive, they are very aggressive tumor. When there is a ductal component, they are very aggressive tumor. And this patient has to have a genetic evaluation. Always we have to explore the possibility of radical prostatectomy if the patient is not, is not a candidate for active surveillance. And in high grade and high risk patient is better if non-metastatic RP followed by whenever there is a RP is required, just to add as a multimodality will be better. Preservation of erectile function is a prime important thing. If you are going for a RP, you should be well versed with nerve preservation, otherwise patient will be suffering lifelong. And more studies are required in CA prostate in young adults because these patients are very heterogeneous group. There are a lot of genetic abnormality in this group. The treatment can be very different in different population. The outcome research is also very important. So, thank you very much.
Ginil, thank you. It's a wonderful presentation.
Thank you, sir.
Now, you made a point very clear that many of these patients who present to us are presenting in a very aggressive mode at an younger age group, maybe because of genetic alterations or hereditary things that is associated with them. And they have a potentially very long life to go. So the treatment complication that happens because of this is also there. And in this potentially long life, there is a chance that they become metastatic, meaning castration-resistant CA prostate. They can develop neuroendocrine tumors, which will be very difficult for us to follow up and manage. So the initial treatment itself should be a little more aggressive. These points are excellently made by you. Now, one big thing, a dilemma that has come for all of us after attending this meeting is we thought about opportunistic screening. Opportunistic screening, patient comes to you at 55, 60. At that time, maybe we do an opportunistic screening for CA prostate. Now that you have shown the data below the age of 50 is around 2 to 9% of CA prostate, and the Indian data is almost 1.81. So when do we start opportunistic screening when these patients come to us with an obstructive symptoms?
So what I will say is any patient who is undergoing any treatment for voiding symptom should have a PSA, and we cannot neglect the chance of malignancy before we are attempting anything on the prostate, even a dutasteride or anything. We have to go for a PSA screening just to see the baseline. So PSA in younger age group is not 4 or 5, it is 1 at 40 and around 3, any value more than 3 beyond 50. We have to 2.5, 3 around 50, 55. We have to go for a, so in European, this is European guideline, 3 is the cutoff for evaluation in this below 60 age group. So we have to aggressively evaluate with MRI in this patient. When there is a doubt, it is always better to evaluate rather than neglecting it, because it is more important than diagnosing a CA prostate at 75. This patient, if you are missing, we may be missing the prostate, and he may not come back to us before they progress to a metastatic prostate. And also they may have some genetic abnormality, and this we may miss. And next generation also may be affected. So it's very important to have a PSA at least. And if there is any doubt, 1 PSA or above at 45, or any family history of any of the hereditary disorders, we have to have screening itself at 40, 45, 50. We have to have PSA. And if there is any borderline, like if it is above 1, we have to either do an MRI or closely monitor the patient.
I think the point is very well made by you here, because when a patient comes to you with obstructive symptoms, irrespective of age, if he happens to be male, let us do a PSA, because the PSA cutoff value, as said, is well below 2.5 for the age of 60 and around 2 to less than 2 below the age of 50 and 1 below the age of 40. And nobody will find fault for doing a PSA for us, because there is a chance of prostatitis also as a presenting symptom. Nothing wrong in doing a PSA. I think irrespective of the age, when a patient comes to you around 30 or 30 plus, better to do a PSA for all our patients that come to voiding symptoms. Is that, Ginil, what you wanted to say?
Yeah. So PSA is age specific, and any intervention for voiding symptom, if is not a congenital or if it's a traumatic stricture or something, we have to go for a PSA and just confirm that. And we cannot neglect like CA prostatitis if the PSA is elevated.
Perfect. Yeah, Dr. Girish.
There are 2 questions, sir.
Yeah,
there are 2
Girish
questions, President, sir.
Yeah. Please go.
Yeah, sir. Girish sir has put 1 question. Is that in younger patients, when you find a cause, how many of them have families, which is relevant, like it's a familial run disease. Did you find any, I mean, what is your opinion on families when it comes in young?
So,
is it aggressive tumor?
So BRCA is the commonest thing we have to check in this family. Our data from our side is around less than 1% only has got the familial this one. So is very low. Like even in young age, the chance of hitting a around, I think less than 5 is the percent I remember in the young age.
Sir, 1 more question for Ravi.
Yeah.
Sir, if he is there. Sir, or else Changal Ran can address, because you have experience. If you have LUTS in young male, when do you recommend urodynamic study, sir? Is it same like if you have neurological condition, or sometimes when you have doubt, will you recommend neurogenic study?
So the recommendations for doing a neurodynamics is whenever the male who is presenting to you is less than the age of 30, or above the age of 80, or the patient has got an obvious neurological lesion, or your size of the prostate or your symptoms doesn't correlate. So there is one clear indication whenever the patient is less than the age of 50 and presents to you with symptoms of LUTS, there is an opportunity to do a neurodynamic. This is a theoretical thing. But practically, sir, in our practice, we see most of these patients correlate with our diagnosis. So many a times we hold the course of treatment. If we don't respond, only we go for urodynamics. As a routine, we don't do urodynamics. Dr.
Sir,
Ginil, your
Sir,
opinion on that?
Ginil,
Hello?
Ginil, sir.
Yeah.
I just missed the question.
Ginil, sir.
No, is a routine neurodynamic essential in patients, younger patients? The answer which I gave was, although theoretically it is accepted that a patient presents you with less than the age of 50 with an LUTS symptoms, you do a neurodynamic. In our routine practice, we actually don't do that because many a times our management actually helps in these patients. Whenever our management is not helping these patients and we have a doubt, that is where we go for urodynamics.
So how I used to do is actually I assess the symptom. If there's a predominant irritative symptom compared to obstructive, then there is a high possibility that there can be some abnormality. If it's a predominant, then if there is a feature of mechanical obstruction like prostomegaly or something, again, and pattern of voiding symptom usually can predict whether there's any concealed neurogenic factor. So otherwise, urodynamic routinely may not be much useful, I believe.
Sir, Ginil, sir, I have one question.
Yep.
In young patients, when you diagnosed with localized prostate cancer, if the patient opts for radiotherapy, usually after with whatever advanced radiotherapy facilities we have, what is the erectile dysfunction incidence?
No, radiotherapy actually the concern is there is this one European NEJM article long back, like the erectile dysfunction in radiation versus RP. So radiation is not like it doesn't have any chance of erectile dysfunction. Because this radiation, there is a possibility of the hormone we are giving sometimes cause abnormality, and the impact of the hormone is for years. And in that paper, actually, we find that erectile dysfunction long term, if you are properly doing a nerve restoration, probably that would be a better option than giving a radiation, because we find that if you are able to do a nerve restoration, almost 80% of the individual, more than 80%, we can preserve the erectile dysfunction. And compared to that, if you are comparing the side effects, long-term side effects of radiation, probably this minute possibility of erectile dysfunction may be a better choice. So there is around, if you are properly doing a nerve restoration, majority of almost more than 80% of the patient, the erectile dysfunction will be preserved, and the rest majority we can have additional support with medication, or if you want, we have got other options also. So that may be a better option in young individual compared to a radiotherapy. But radiotherapy also significant, around 40 to 50% of individual had long-term erectile dysfunction in that study article.
Thank you. Thank
One
you. Two
more
more
question
questions.
from the audience, sir. One more question from the audience that in young patients also, do we do MP-MRI or directly we go for biopsy? I think
no, all the
not any difference.
Now there is no confusion about MP-MRI. All the biopsies we have to have a MP-MRI prior to biopsy. If we are planning for a biopsy, have a MP-MRI and do a biopsy.
And Chandramohan sir, I think there is one more question which I saw, which said if initial PSA evaluation was normal in a patient where we have done an opportunistic screening, when should we repeat the PSA? I think the answer for that is 2 years, if I'm correct.
Actually, what so if PSA is high, when we have to, or
no, if the PSA is normal on a routine evaluation, there is an opportunistic evaluation. If the PSA is normal, how routinely you have to repeat the PSA?
So that based on the risk possibility for that patient. If there's a family history of patient, family history of CA prostate, we cannot leave him alone. And below, what we usually do is 40, 45 and see the increment. If it is borderline, we have to have like if it is just beyond 1, we have to have repeat and have MRI. If it is below 1, we can wait for 5 years and repeat a PSA. Then again, if it is, we can assess the change. So the every year is the recommended thing in beyond 50, 1 to 2 year, we have to have a PSA if there is a possibility of malignancy. So every yearly PSA is there.
At least once in 2 years we need to.
Yeah,
as I said,
1 to 2 years we have.
once we did a health checkup.
Sir,
That
one
based
more
on
question
what is
by
the level of PSA and what is the chance of in the risk for that patient.
Sir, one more question by the same person who asked for MPMRI. He has written NDS. I don't know his name. Sorry for that. If MPMRI is normal or pyrites 1 and 2 and PSA is 7 in young male, will you repeat PSA after 2-3 months or directly you will go for standard sextant biopsy?
No, if PSA is low, what in my this thing, what I used to do is I just give a course of antibiotic and recheck. That is actually not the standard of care, I will say. But why I'm doing is in our population we had a study, and what we seen in that this was actually a thesis paper when the PSA is significantly reduced with the antibiotic short course, then the chance of having a malignancy was less. If it is not responding, then the chance. So that is why how I. But it is not actually a standard of care because if culture is not negative, we should not depend on the antibiotic is the standard of care. But in our population, I feel that more studies are required on that aspect. At least in our study, we found that there is a group where they respond to PSA, and those patients were actually what we found is if there is more than 50% reduction and the final PSA is normal level, then the chance of malignancy is very low. So that was actually because of that we are just doing that. Otherwise, we have to have a PSA follow-up if the PSA is borderline. So that depends on 1 year, 2 year, or 5 year, depend on the value of the PSA. So if a elderly patient, if the PSA is less than 1 or beyond 50, we can have a 5-year PSA according to ERS-SPC trial. So this is actually depending on the PSA level and the chance of, if there is a family history, we have to have a close monitoring of this patient after 40, between 40 and 50. So depending on that, we will have a follow-up. If the MRI is normal, PSA is very much normal, actually we can have even 5 years or so is the option. The PSA is very low.
I think, Ginil sir, I think what the person was more into it is asking was the PSA is persistently high, but your MRI is showing only a pyrites 1 or pyrites 2.
So if one more PSA, if it is high, we will go for a biopsy. That will be a template biopsy.
That will be template biopsy in spite of the fact that, if the MRI is normal also, if the PSA is
we will have a template biopsy.
On a safer side, better go for a template.
Preferably a transperineal biopsy.
Preferably transperineal.
The small prostate with a high PSA. Size of the prostate and the rise in PSA is significant, sir.
So there's a paper from Aravind Gandabale team. They found that our PSA density is high and PSA is the PSA prostate size is low compared to the. So that was a few years back. They had screened the entire district and found that our PSA density is slightly high compared to the Western population. So we have got a small prostate with probably.
I think the wonderful, two beautiful topics selected for today. A lot of discussion came up, and people are interested to ask more questions also. But time is a constraint for us. We are already almost close to 8 o'clock in the evening. Yes, Secretary sir, please.
Fortunately, today maximum attendance was 45. In the webinars of ASU, this is good attendance, but we expect in future more attendance. But still, people have attended and asked the questions. And I appreciate Dr. Ravi Kumar sir and Dr. Ginil Kumar for presenting extensively, and then detailed discussion also happened. And we also learned few points today, and wish such webinars will be conducted more and knowledge is shared. Thank you once again the speakers, and thank you ASA President Dr. Chengoloyan sir, who is actually planned this program for the youngsters who want to learn the LUTS and carcinoma prostate in young. Again, with this, we conclude the session.
I think we need to track our academic partners also. CIPLO has helped us in this program for organizing.
Yes, sir.
And as our
Yes,
secretary said, the participants, although comparatively were less, I felt all 45 were very active. Everybody was listening. Everybody was very active today. It's really
Yes,
a
sir.
big boot to ASU, big boot to ASU.
That's good, sir.
Yeah.
Thank you.
Thank you very much.
So
Thank
with
you
this,
very
we
much for a
conclude, sir.
wonderful
Thank you.
program. Ginil, Ravi, wonderful job, sir. Both of you did a wonderful job. We were all interested. None of us went out. None of us turned right or left. We were listening to your presentations. A lot of doubts that came to us. And Ginil Kumar, sir, after your talk, we are all worried. All people who come to us above the age of 30 now, we will be doing PSA for every one of them.
That is because you have given me a topic like that.
Your experience
You wanted to get worried. That is why you gave me that topic.
Good. Because your experience on treating a lot of these patients in your center.
No, that incidence is around 3% in below 50. That is not a big percentage in which the number of patients in that. But thing is, we should not miss that 3%. That is more important.
Perfect.
I really don't understand why the American government stopped
No,
doing.
they have restarted now in a minimal way. Actually, they have restarted. Basically this data, whether we can utilize in our community without, because we are seeing more of aggressive tumor than the West. So even if they are missing a tumor, it may not be much difficult for them to catch it later. But our community, we are out of one of my paper, we found that more than 80% of my radical prostatectomy patients had a high risk CA prostate. So that is the way in which we are seeing the patient. So we cannot follow the American guideline, and Americans find that the death rate is increasing, so they have gradually incorporating the actually opportunity screening and all these things into the practice now.
Thank you, Ginil sir. Any more questions, Chandramohan sir? Would you like to entertain? I think
No,
one
sir.
question
No, sir.
came.
Somebody appreciated. Somebody told that will they repeat the PSA after 3 months if it is raising MPMRI. That's what Ginil sir told. In India, one high raised PSA suddenly in youngster going for biopsies may not be correct. Giving one course of antibiotics, taking 2-3 months time, even if MPMRI is normal, repeat the PSA and then proceed may be better option. That's what Ginil sir said, and I think that's logical.
Thank you very much. Thank you, everyone. I think Chandramohan sir, you can give one final concluding remarks and we'll finish the session.
Yes, sir. So I thank the speakers, Ginil Kumar sir and Ravi Kumar sir, and also I thank CIPLA company for sponsoring the program. I also thank ASU president once again, who is actually part of the program with including the topics. And I thank the attendees, more than 30-40 members attending this program. Thank you once again. Good night, all of you.
Thank you.
Thank you all. Bye. Good night.
Good night.